Good morning, Shabbat Shalom. I'd like to make this brief talk about single bone nailing for displaced two bones, forearm fractures. So the aphyseal forearm fractures in pediatric population are very common, and depending on different reports, it can be 3% to 6% of all pediatric fractures. Most of these fractures are really successfully treated by a conservative treatment. According to this report by Flynn from JPO, up to 85% can be treated by reduction and casting. Intramedullary nailing has become the gold standard for unreducible or unstable pediatric fractures. It has many advantages. It is stable enough for fracture healing. It enables us to do close reduction in some cases. It's minimal exposure if we do need to do an open reduction, and it's very easy to remove after the end of treatment. Our treatment protocol for this kind of fractures, we first, of course, start with close reduction and casting under sedation. We mobilize it with a splint or circular cast. We do try to avoid multiple attempts because of the fear of compartment syndrome. And the bottom line is the non-acceptable realignment is an indication for closed or open reduction with intramedullary fixation. For the surgery, we use a 2 or 2.5 titanium elastic nails for all our cases. We always start with a more displaced bone. This is the first one to be reduced and fixated. And we do have a very low threshold for open reduction, again, because of the fear of compartment syndrome. Well, the question is, should we always nail both bones? If you ask the Nancy group, those who have developed this technique, the answer is very, very clear. Lascombe in this paper used and abuse of flexible intermediary nails, emphasize that in all cases, 2 nails should be used. They should be pre-bended for increased stability. And in this way, it stretches the intraosseous membrane and increases stability. The first to describe single bone fixation for these 2 bone forearm fractures were Flynn and Waters, JPO 96. They treated 17 patients. They fixated the radius and the ulna. They used plates and nails, and they concluded it offers a safe and effective solution for this kind of fractures. The principle is to stabilize one bone while the other one is rotated and angulated into reduction. And they did compare both methods and say that they liked more the intramedullary fixation because the hardware is easier to put in and it's easier to take out. Another interesting review is that this is a review of 8 studies with single bone fixation that concluded that it is a suitable method with comparable results to both bone fixation. They did show that they have better results when the radius was fixated and not the ulna. And they emphasized that second bone should be left unfixed if it is reduced and stable. This last paper I want to show you is also by Waters. They took 38 children and treated them with intramedullary nails of the ulna alone, just the ulna. And they concluded that it has a good short-term stability and good outcome. And they didn't mention that we should nail both bones in cases of open fractures or in older children. This is because of diminished remodeling potential. So back to our protocol, we reduce and fixate first the more displaced bone. After we do that, we assess the stability of the forearm. We check the alignment, the axis, and the shortening of the second bone. As I said, the second nail is not always needed, and decision is, of course, always made intraoperatively. We never make the decision before. So a bit more than 3 years, we operated 110 pediatric patients with 2 bone forearm fractures. In 75 cases, we performed fixation of both the radius and the ulna, and in 35 cases, we performed a single bone fixation of the radius or the ulna. And we wanted to see the results of single bone fixation. So from the 35 fractures that were treated with a single bone, the average age was 9.5 years with a range of 4 to 14. We had a very strong male predominance with only 4 girls in this group. In 28 cases, we fixated the radius, and in only 7, we fixated the ulna. We had 28 open reductions compared to only 7 closed reductions. Again, this is because of our low threshold for open reduction. All forearms were put in above elbow splint or cast after the operation. A reduction of the unnailed bone was examined again after we finished the operation. We did the casting and molding, and we checked it with fluoroscopy to make sure that we have satisfactory alignment. Our results, all 35 cases reached bone healing in 6 weeks of follow-up. 3 patients had some limited supination with an average of 10 degrees deficit. 2 patients had some pain with activity that resolved after a few months. We had no case of compartment syndrome. And we had 1 patient who had refracture in the same location after a minor trauma. But this shows you that even having 2 nails inside does not prevent that complication if you have a secondary trauma. I'll run quickly through a couple of examples. This is a 14-year-old boy treated primarily with closed reduction and casting. And intraoperatively, we nailed the radius. The ulna was left unfixed. You can see it's 10 days post-op in a cast. You can see the minor angulation and the translation. And it healed well after 6 weeks. The cast was removed, and this is 9 months after the operation with no pain, good range of motion, no limitation in prosupination. This is an 11-year-old boy treated with closed reduction and casting. We nailed the radial bone. This is 1 week post-op, and this is 5 weeks post-op after cast was removed, again with good clinical result, with good range of motion and no pain. The last example is a 4-year-old boy with refracture a few weeks after the cast was taken off. You can see the angulation and translation of both bones. Again, only the radial bone was fixed with the ulna left with this translation, as you can see here. This is intraoperative pictures. This is 1 month on the left-hand side and 2 months on the right-hand side, again with good results. So to conclude, single bone nailing offers the advantage of being less invasive, more simple, and more safe. In our series, there was no case that required a second surgical procedure for loss of reduction or of non-union of the unfixed bone. Of course, we emphasize that care should be taken to correct both angular and rotation alignment to the unfixed bone. In this cohort, the radius was fixated in 80% of the cases, and we think that's because the radius was more displaced primarily. So we believe that when the unfixed bone alignment is restored and length maintained, single bone fixation offers a good surgical solution for this problem. Thank you very much.